Okay, we're here at the 2017 AUA in Boston. Lots going on. The meeting's going to wrap up soon. I'm here with Quoc Trinh, who, of course, wears many hats. He works with AUA publications, as well as the British Journal of Urology. Yesterday, for starters, he gave a very nice talk at the International Prostate Forum at the AUA, and we were on a session on comparative outcomes research. I think it's a very interesting area, and I'm still learning about it myself. Quoc's been one of the pioneers on this. So we specifically had other talks around yours on, of course, randomized trials, tertiary care databases, but your area, of course, is health services research. Tell us some of the bullet points on secondary data analysis and what's new in health services research.
Sure. So I gave this talk on secondary data analysis, and there's obviously been a lot of interesting work out there. The secondary data analysis is using data that was not collected specifically for you. There's obviously a lot of breadth of data out there that you can use, and from the economical standpoint of using secondary analysis, you can do these kinds of study relatively cheap because the data has already been collected and of decent quality because it was done specifically as part of a larger project. One of the things I said is really exciting about secondary data analysis is when you can do some sort of linkage. So some of these data have already been explored, something like the Seer Cancer Registry or National Cancer Database. But when you're able to take some of this data and put it with something else, for example, in Dan Barocca's study that was published maybe 2 months ago, where Seer and capture data was linked to patient-reported outcomes that was prospectively collected, well, you get some really exciting population-based data on the differences in endpoint outcomes between surgery, radiation therapy, and active surveillance for prostate cancer. One of the interesting questions, actually, John asked that question during my presentation, was to say, are these data able to modify guidelines that impact on practice? And I think the answer is yes. In some ways, not everything can be put forth as part of a randomized controlled trials. And also part of the problem is that randomized trial surgical techniques have obvious limitations that were highlighted by many people. So certainly secondary data analysis, population-based studies can inform us on how we should be practicing. And as I said, when you link it to data to be able to get a little bit more depth in your analysis, you can really impact clinical practice.
What were some of the papers you want to give some punchlines on, like sort of the more high-impact HSR and prostate cancer was our topic from yesterday?
Yeah, there's actually a lot of really interesting work that has been done as part of this meeting. I think one of the big policy questions from a health services, health policy perspective is the effect of accountable care organization on prostate cancer care, urology practice in general. And I think there were many posters, many podiums that were dedicated to this question. Some by the Vanderbilt group led by Matt Resnick, some work from the Michigan group, David Miller and company, some work that our group also done on accountable care organizations. And it's somewhat equivocal. It seems that from a urology perspective, we don't seem to have necessarily that much of an impact in terms of improving the quality of care of our patients with prostate cancer. So I think that was a pretty interesting recurring theme from what we could see, at least at the AUA this year, in multiple different sessions.
Tell us about the coding one, too. I think a lot of robotic prostate surgeons would like to know that narrative.
Which
the coding on, they wanted to change the Medicare.
Oh, yeah, sorry, yeah. So, this is always like, how can secondary data analysis potentially impact clinical practice, and sometimes in a really small way, but important way. So one of the things that the Center for Medicare and Medicaid Services did a couple of 24 months ago, is that they felt that based on their review of the evidence, there was no justification for providing more RVUs for robotic prostatectomy, and as a result, it decreased the RVUs for prostatectomy by a significant chunk. and the AUA gave provided some pushback on that and cited a number of studies, including one study that was by Liao et al. From our research group, and we leveraged a premier data set to explore the cost, the outcomes, the operative time of robotic prostatectomy. And what was really interesting is that the CMS actually changed back the RVUs for prostatectomy and increased it back to 26.8, and specifically cited this study saying that the operative time is longer and there is some level of benefits, at least from a population level, of robotic prostatectomy, and as a result they were happy to increase the RVUs back to 26.8.
All right, well, thanks. Have a good meeting.